Dr. Heng from Cambodia as panelist for today. So, Dr. Nilla, please. Okay, can you share your slide? We cannot hear you. Okay, Dr. Nilla have some network problem, so maybe ready in a few minutes. So, Dr. Heng, how are you?
Good morning, Professor Kim. I'm good. Thank you. And you?
Yeah, excellent. Yeah, okay. Yeah, we cannot still, yeah, cannot hear anything from Dr. Nilla. Maybe some problem in your mic.
Hello, can you hear me?
Yes, we can hear you, but there is some howling.
Yes. Please wait. Sorry for my.
Now sounds great.
Yes. Oh, sorry, I have some problem in joining Zoom.
We cannot hear you.
I have problem in sharing.
Some howling, but now we can hear your voice.
And can you see my screen?
Okay, perfect.
And also hear my voice well?
Yes.
Thank you. So, good morning. My sincere greetings to Dr. Wan and all the professors and colleagues joining from each country. I'm Nila, presenting from Myanmar, and I completed the fellowship with the Korean Heart Rhythm Society last year. So it's a great honor to present again today EGM conference. So let me begin my presentation. A 29-year-old gentleman with a height of 170 centimeter and a weight of 68 kg, who came to us with a complaint of palpitation off and on. The episodes have a sudden onset, occurring around 2 to 3 times per month. So far, there has been no documented tachycardia, and the episodes resolved spontaneously. His physical examination was unremarkable. Routine blood tests and laboratory investigations were all within normal limits. The presence of any form of structural heart disease was ruled out by transthoracic echocardiography. So at this stage, we were considering possible causes of PSVT and continued further evaluation, including EP study. His chest X-ray also revealed normal. At the beginning of the EP study, shortly after catheter placement, the patient developed a clinical tachycardia. So before I move on, does anyone have any interpretations or impressions of this ECG?
Thank you, Dr. Nila. For me, I think it looks like wide complex tachycardia. I don't see any AV dissociations. It looked like left bundle brain block to me. So my concerns about my first diagnosis is an SVT with aberrations, left bundle aberrations, I think. Is there any participant who have idea also? Please share your idea also.
Maybe just point out quickly. Can you hear me?
Yes.
If you look
Yeah.
at the end of a QRS complex, there's a small notching at the beginning of a SCT wave. That might be P wave. Okay? You come up to that segment, come up just before the small indentations that you see. That's all basically what you can say. Could it be a SBT with the aberrancy or, you know, some sort of a tachycardia 1-to-1. You cannot exclude the possibility of unlikely, but BT with the 1-to-1 VA conduction as well. That would be consideration here. Okay.
Yes. So
Okay.
can I move on?
Yes,
Yes.
move on, please.
It's a regular white QRS rhythm with left branch block morphology, left superior A6, and precordial QRS transition between B4 and B5 with no preceding P wave. So based on these findings, our differential diagnosis include right free wall antithromic AVRT in WBW and VT anti-proven otherwise arising from RV posterolateral wall and pre-excited tachycardia using the right-sided atriovascular SSI pathway, so-called MAHIME. So we needed further electrophysiological evaluations and mapping to differentiate among these mechanism possibilities and confirm the mechanism. So we then recorded the same tachycardia at a faster speed, which allowed for more TT analysis. The tachycardia cycle length was measured between 310 to 330 milliseconds, and notably in the inferior leads, 2, 3, and AVF, we observed a possible atrial P wave appearing at the end of the QRX complex and ST segment junction. So this is one of the points that favor BSVT over VT. So catheter placement was done with consideration for the differential diagnosis. A Dagabula catheter was positioned along the TV annulus in the right atrium. Closely spaced duodecabular catheter was placed to span the RA septum, his bundle region, right bundle branch region, and RV septum, allowing for TT mapping across these stretches. And then another quadripolar catheter was placed at the mid-posterolateral wall of the right ventricle, targeting the suspected site of origin for the possible VT or accessory pathway. So this slide demonstrates the EGM signals recorded from each electrode corresponding to their respective catheter positioning during the sinus rhythm. As you can see, the earliest activation was observed at the RE electrode 7 and 8 with initial negative far-field signal. And nearly simultaneous activation was seen at the electrode 3 and 4, which displaced an early positive far-field signal. And similarly, the electrode 5 and 6 demonstrate the signal with biphasic local EGM. So all these findings suggest that the sinus activation is orientated almost perpendicular to the orientations of the HRA catheter. And then we follow along the sequence. You can see that the proximal electrode 90 and 20 of the subduodecabular catheter showed early subatrial activation with far-field His signal. And then good His signal potential was recorded on the electrode 17 and 18, accompanied by far-field negative VEGM representing subdural V activation. And then distal His was recorded on the electrode 13 and 14. At this level, the subdural V far-field signal became positive, suggesting transsubdural activation from left subdural, merging with the right bundle activation potential. And local VEGM was seen at the electrode 9 and 10. And then when you look at the RV free wall catheter, the proximal electrode activation timing was similar to the subdural electrode 13 and 14. But when you look at carefully, the signal showed the sharper R wave, followed immediately by local ventricular EGM, likely reflecting moderator band activation. So this orderly progression helps confirm proper catheter placement and also provides a baseline signal identifying any conduction abnormalities later on. So when we initiate pacing maneuver, you can observe a noticeable shift in the activation sequence evidenced by significant QRS morphology changes in lead 1, 2, and V1. Importantly, the HP interval remained unchanged, and there was no alteration in the His bundle EGM. However, RV distal EGM appeared slightly earlier compared to the sinus rhythm, indicating there may be pre-excitations of the ventricle. So these findings support the presence of antegrade conducting accessory pathway consistent with WBW syndrome at this stage. So this tracing was one of the key tracings that guided us towards the target diagnosis. During the recording, we observed two wider QRS complexes with same QRS morphology, but varying PR intervals. So the first wide QRS complex was associated with shorter PR interval, and we cannot see his signal in this beat. So because accessory pathway contacts faster than AV node initially. As the pacing continues, the PR interval progressively increases, but QRS remain pre-excited, suggests that AV node is delaying, but accessory pathway is maintaining antegrade conduction via itself or fusion with AV nodal delay. So when the PAC from the distal eye occurred early, but at that time AV node is still refractory. So the impulse contact via the accessory pathway, which is still able to contact. So important point to note here is that typically conduction through the accessory pathway results in shorter PR interval. However, in this beat, PR is prolonged, which indicate decremental pathway contacts more slowly or faster despite persistent pre-excitation. So this is the summaries of this EGM. So we have the 7 beats in this EGM. So PR interval for the first beat and last beat, PR interval short, long, and during these beats are lengthening, QRS morphology, wide and fully pre-excited, the same morphology with first and last beat. And his signal is absent or follow QRS in the first and last beat, and you can see clearly his signals in between beats. So the conduction is fully via the accessory pathway for the first beat, and AV node progressively slowing and accessory pathway contacting increasing, while the PAC during AV nodal refractory period shift to accessory pathway conduction. So the mechanism may be for the first beat, first conduction over accessory pathway, and these beats are with fusion and slower conduction over the accessory pathway. So this is the end of the eye proximal pacing. PAC arising from this at this time resulted in antegrade block at the AV node, which was conducted via the accessory pathway, leading to pre-excitations of the RV distal. So this was again followed by retrograde conduction via the AV node, producing an echo beat. So confirming the presence of both antegrade decremental accessory pathway conduction and intent retrograde AV nodal conduction. So this was evidenced by a retrograde right bundle potential that appear earlier than the proximal RA activation. So in this sequence, the first complex is sinus beat, followed by atrial pacing. With continued atrial pacing, we observed a gradual increase in ventricular pre-excitation, and the HP interval progressively shortened, eventually becoming negative. So that indicates the decremental conduction. This pattern represents progressive fusion conduction between AV node and accessory pathway. Important point we should be aware of here is this. The progressive pre-excitation lasting more than 2 beats is unusual for a typical right free wall accessory pathway. in right free wall associated pathway, which generally contacts rapidly and non-decrementally. So we can rule out the right free wall associated path AVRT in WBW here. Instead, this behavior is more characteristic of a decrementally contacting associated pathway, such as atriofascicular Mahi fiber. So when we're doing the atrial stimulus, QRS complex changes, and pacing from the eye proximal electrode, S1 demonstrate the decremental conduction via the accessory pathway evidenced by variable degree of pre-excitation on the QRS complex. During S2, there is a prolongation of AV nodal conduction, AV conduction accompanied by the narrow QRS complex, indicative of less pre-excitation. So this reflects more fusion between accessory pathway and AV nodal conduction. The resulting delayed conduction through the AV node provoke an AV nodal echo. So the red dot mark complex represent the dual AV nodal conduction with AV nodal echo. Notably, the RV EGM morphology differ between S1 and S2. During S1 pacing, in the posterolateral RV electrode records a distinct signal that includes a Purkinje or distal fascicular potential. This potential is absent in the S2 complex, suggesting a change in the activation sequence due to altered conduction pathways. So with S1 at a cycle length of 500 milliseconds, there is minimal pre-excitation, suggesting predominant AV nodal conduction with only limited accessory pathway involvement. However, when an S2 atrial stimulus is introduced at 230 milliseconds, the AV nodal conduction is blocked. As a result, the conduction proceeds exclusively via the accessory pathway, producing VA conduction and generating a AV nodal echo beat. When you look at the EGM during S1 pacing, the activation sequence from his bundle to right bundle is clearly proximal to distal. In contrast, during pre-excited S2 complex, the distal subtle region of RV apex is pre-activated earlier, and then there's a retrograde activations of right bundle and his bundle. So the reversal of activation suggests conduction through subtle or possible atriofascicular accessory pathway, bypassing the AV node entirely. So this is the similar mechanisms of earlier slides with true white QRS complex with PAC. So it means it's a consistent finding. This tracing illustrates both AP conduction and AV nodal block. So this slide shows the RV posterolateral wall catheter induced non-sustained to AVRT complex. This is the sinus beat with deliveries of S2 and S3 atrial stimuli from the proximal eye resulted in more pre-excitation. This pattern reflects decremental conduction over the accessory pathway, while AV nodal conduction is simultaneously demonstrated progressive delay. So at this stage, from the RA pacing, we can conclude the patient had the antegrade decremental conduction. So we move to the RV pacing. During RV posterior subtalar pacing, retrograde conduction is observed through the right bundle and his bundle, followed by atrial activation consistent with VA conduction. Decremental VA conduction through AV node resulted in induction of tachycardia accompanied by maximal pre-excitation, indicating dominant condition over the accessory pathway. So progressive shortening of the S1, S2 interval demonstrate decremental VA condition, and tachycardia is induced during this pacing sequence with the earliest retrograde atrial activation recorded at the septal region. Notably, retrograde activation of his bundle is observed, indicating VA condition is occurring via the AV node. So when we delivered PAC on the his bundle, tachycardia did not affect the cycle length, suggesting the his is not part of the antegrade limb of the tachycardia circuit. And during tachycardia, earliest ventricular activation occurs at the RV distal, specifically at the posterolateral wall. However, the activation time difference among RV EGM are minimal. Some RV signals are preceded by sharp potential, likely conduction through right bundle and his. Additionally, the two S2 extra stimuli from the RV failed to reset or advance the tachycardia, indicating that the best site V is not involved in the reentry circuit. So shorter S2 pacing produced similar response with retrograde his bundle and RV and his bundle activation visible. So this finding suggests the involvement of right bundle and his bundle in the orthodromic limb of tachycardia circuit. So here we can conclude that our patient had the antegrade decremental conduction pathway, atriofascicular Mahan fiber. So we started to map the Mahan potential along the TV annulus. So during mapping, we use a pullback technique to minimize the risk of mechanical pumping of the accessory pathway. So SL1 sheet was used to provide stable catheter support here. This is the successful EGM. At the successful ablation site, you can see the distal bipolar EGM demonstrated a typical Mahan potential located at the TV annulus. The A and V signal were nearly equal amplitude with that atrial component slightly dominant, suggesting more atrialized signal. Importantly, no far field V signal was seen in the proximal bipolar. So usually the Mahan potential often resembles a His-like signal and is prone to mechanical pumping. Of particular concern is when the local activation timing matches that of the His bundle. So in such cases, it is essential to reconfirm the catheter position using the LAO view. The ablation catheter should appear more right lateral compared to the His catheter to avoid inadvertent His bundle injury. This overlap in appearance and timing can occur due to the oval anatomy of the tricuspid valve, where septal to lateral distance may be shorter than we expected. So we can successfully ablate the Mahan in that area. These slides demonstrated preserved AV nodal conduction following ablation. This slide also shows the AV nodal conduction, and AV nodal wonky bar was observed at progressively shorter cycle length, indicating that intact but physiologically decremental AV nodal conduction. So this tracing also demonstrates dual AV nodal physiology with an echo beat. The earliest atrial activation is recorded at the septal region of the electrode 13 and 14 without any valve His signal, supporting a nodal but not His dependent retrograde conduction pathway. This tracing demonstrates retrograde VA conduction via the AV node with decremental properties. So as a conclusion, our patient present with a atriovascular accessory pathway located along the free wall of the TV annulus in the setting of dual AV nodal physiology. So the accessory pathway demonstrate decremental antegrade only condition is consistent with the typical Mahan physiology. So there are some typical Mahan characteristics which include decremental conduction properties, can be sensitive to adenosine, and wide complex tachycardia with left pendant branch block morphology, and late wave transition, and frequent tachycardia episodes can be due to large excitable cut supported by decremental properties in both antegrade accessory pathway and orthodromic AV node lip. So there may be some variant form. Some right free wall accessory pathway exhibit antegrade only decremental conduction without a recordable high potential. And other may demonstrate a bidirectional conduction with minimal decremental property, distinguishing them from typical Mahan pathway. So this is the rationale for this presentation. The reason I chose this case is to highlight the beauty of pacing maneuver in differentiating tachycardia mechanism. To be honest, we often tend to rush into ablation and give less time to detailed pacing maneuver. Actually, this case was performed by Dr. Wan and me during his visit to Myanmar in March. Although the diagnosis is established early using RA pacing, Dr. Wan continued to demonstrate the characteristic electrophysiological features of Mahan fibers through various pacing maneuver, not only to confirm diagnosis, but also to illustrate their unique conduction properties. So as I reviewed this case repeatedly, I found myself enjoying the EGM more and more. Every signal is pointing the way to the target step by step. So today, I hope I could share not only the clinical insight, but also that sense of EGM enjoyment with all of you. That's the main reason I'm presenting this case. Thank you.
Thank you. Excellent presentation. Hang. Chad, you there?
Yeah, I'm here, Dr. Wong.
Okay.
So thank you so
So
much.
you're the guy supposed to be commenting this.
Okay. Actually, it's look at once to me. So anyway, thank you, Dr. Nila, for the very nice presentations and so also very detailed EGM interpretations for us today. So I have one questions for you. So what is your I mean for the first catheter positioning, you don't put a CS catheter, right?
CS catheter for the along the TV annulus in the eye, right? Yes?
No, I mean coronary sinus catheter.
No.
Could you tell us why?
Because from the ECG findings, we can get the diagnosis of right-sided pathway, and we can locate the right free wall. So I think we don't need to put the CS catheter.
Thank you, but I think that for my idea, it's most likely, like you said, it's a right size accessory pathway. But anyway, we like the previous discussion about ECG, we are not sure about multiple accessory pathway in this patient. So maybe the CS catheter is also one of the options during the EP study, I mean. But anyway, after during the mapping, we can move the catheter to the right side for more detailed mapping.
So I have one question for you. You said you think multiple accessory pathway in this ECG. Could you explain me which points?
Not based on the ECG, but based on the study that even patient one have one accessory pathway, they might have another accessory pathway at the same time. Even the rate is around 3 to 5% only, but I think it's better for my idea only. it's better to have one CS catheter during a complete EP study. So we might have more idea about the side conductions also.
So thank you for your comment. And may I note the idea of Dr. Wan?
There, anyone has any other question, please? No one has any question? So let me make some, comment about this. First of all, Dr. Maheim is a Belgian. His name is Ivan Maheim. He was born in late 19th century. He graduated from the Switzerland, Lausanne. He went medical school there. But notably, his mentor was Wenckebach. You guys all know Wenckebach. You talk about Wenckebach every day.
Yes.
Dr. Wenckebach is Austrian. He's a University of Vienna teacher. So he was born even way before EKG machines and all that stuff. And he able to figure out, to block Wenckebach just looking at the neck veins and physical examination. So Dr. Maheim was his pupil. And he graduated Switzerland, and even though he's a Belgian guy, he only spoke French. And he practiced in the Switzerland for more than 60 years. Anyway, to be noticed that Dr. Maheim Jr., you all know every day also. Well, I'm his bundle guy. So we are talking that time, brilliant physicians together working in Switzerland, Lausanne Medical Center. Many important papers came out. That is one of these, the Maheim complex we are talking. Now, he published more than 100 papers, all of them well-documented histologic preparation combined with his description. It's very worthwhile reading sometime if you have time. Anyway, this terminology Maheim is an eponym, is not a correct name. Atrial fascicular pathway tachycardia is more proper name. However, we don't want to discredit Dr. Maheim's work. And at that time, there was no really detailed histologic study, only later on that they able to produce this. As far as we know, first Maheim's EP study was performed in 1971. Guess where? In Brazil. Was my school. The Professor Sosa and many other guys participated in that study. They were my teacher, and then they show us these cases. So that's I remember. Now Maheim essentially became important sort of a pathway to understand ablate, because we first tried to ablate this from the ventricle. We are not very successful. And only after the many other people, pathology study, so on, figured that out that we better ablate from the atrium, this pathway. Now, answering Chad's question, do we have a Maheim from the left side? Answer is yes. There is a Maheim from left side, published by Chinese series, about 4 patients, but no one else ever published it since then. So we don't know whether that report is truly true or not, but we don't want to discredit the investigator. But if you look at the Chinese study carefully, AVL, EKG, QRS complex is negative. He said both right and left, which is very unusual for me to understand that. How can be right side, it can be AVL negative. So I really never able to figure that out anyway. So that's something that you need to keep in mind. But according to the report, there should be left side Maheim as well. But those patients should have right bundle branch block pattern, not the left bundle branch block pattern. So when we saw this patient tachycardia induced as placed the catheter, and then we saw left bundle branch block pattern, and then history of a decremental conduction, all that stuff. So we decided to use a decapolar catheter only to the right side first to see. And then we did evaluate after the ablation, make sure there's no other pathway. So that's one way to do it. Other way to do it, that you can put a CS catheter right up front, and then decapolar in the right free wall over the tragus annulus. But a key point here is that you really need to point his bundle catheter, right bundle catheter properly. Otherwise, you're not going to be able to make a proper diagnosis of this type of tachycardia. So that's what I'm trying to point out. If you want to do SBT study, please put a his bundle catheter, make a good his bundle EGM. They only can help you, not confuse you. So that additional extra steps will help you a lot your time, okay? Now there's your third slide, Nila. If you go back there, I'm going to point out to the
Yes.
fellow something. There's one first complex wide, and then there was a narrow complex that wide again.
Yes.
Yeah, keep going. I think one more back.
This one.
There we go. Now, in this tracing is actually, you have to question yourself. How come first complex PR is short, wide, last complex PR is long, still wide? What's the difference here? And then Nila pointed, well, this is a decremental pathway, yes. However, what's the difference here? It is where is the stimulus coming from, okay? So if you look at the first complex, PAC coming from the closed-up pathway, which is a tricuspid annulus 7 and 8, okay?
Yes.
Now, second PAC coming from somewhere else. You see P of activation completely different. Can you see that? That is probably far away from pathway. Therefore, conduction, HI conduction time is long, PR is long. Okay? That point out again, if you're going to study pathway, you better put an HR ventricular catheter close the pathway where you think you are. That way you can pre-excite more, you can easier make a diagnosis. Again, catheter placement. So take a time, think, move a catheter any way you want, where you ideally, then you study the patient. That would be the best thing to do, make a procedure shorter, okay? Now, the last thing that I want to tell you is that if a patient has indeed atrial fascicular pathway, Nila pointed out very well that a very easily bumpable pathway. So you really want to be very much advance the catheter all the way down to the tricuspid annulus, low as you can, and then start pulling back up very carefully, looking at the bigger A, smaller V signal ratio. And then you will find a distinctively small sharp potential force in a proximal, and then you further pull back, you will find in the distal sharp potential like what we saw. Do we need to burn high energy this one? Answer is no. Usually 25 watts to 30 watts, you will be able to get rid of this pathway plenty. So you don't need to burn very high power energy. Only concern is that don't just look at the RAO. Make sure to get the LAO. Make sure your catheter pointing away from this bundle to the lateral wall. Okay, that's the only thing that you need to think about it. But having multi-electrode catheter in the septum, you can demonstrate beautifully retrograde activation of a conduction system from the right friole, then moderate band, cross the septum to the right bundle, activating his bundle system retrogradely. So, Mannheim physiology, basically atrial fascicle insertion is a distal right bundle, which is a lateral to the moderate band. So that way you're going to find the earliest V with a sharp bundle potential preceding pipettic potential. If you're going to target the ventricle, you got to ablate down there. Danger of ablating down there is that you may not create a complete lesion, then patient have an incomplete disconnection of pathway, then you're going to have incessant tachycardia, now pathway exit to the left ventricle. Then your EKG change configuration completely. Then you get very confused about it. So always try to target tricuspid annulus first. That would be the best approach for this, okay? And always use a sheet for the right friole pathway. You know that each EKG conference, Korean guys, this morning, you guys use the SO1 sheet to ablate also that right friole pathway, right? That's a good thing to do. Any other question, comment for us? Anybody has a question?
I have some question.
Please.
Very nice case of atrial vascular pathway. It's really beautiful. So I have a question about the EGM, the extra stimulus 270 bit EGM, please. Yeah.
Okay.
Yes.
Next. Okay, next. Next. During tachycardia. So
Yes.
because the retrograde right bundle.
Yes.
And next, please. Sorry.
Yes, I know.
Here. Or next one.
to 270.
270.
Yes.
It's very, that EGM was very excited. Yeah.
This one.
Yeah, so I think that but you pointed the retrograde right fascicular bundle and his retrograde activation show that, but I think the RV catheter preceding local sharp potential preceding local
This one.
no more anteriorly. So before QRS, before local V, the sharp potential, I think this is the real retrograde conduction to the right bundle and his retrograde conduction because
Why do you think it that way? May I ask you that question?
Yeah.
That's by appearance?
No, because theoretically the retrograde right bundle and his activation very quick, very fast through the
Understood. But let me ask you this question. In sinus rhythm, your right bundle hits was what? Positive or negative? In sinus rhythm, you saw tracing sinus, right? Is it positive?
Yes.
Right? So if you're conducting retrograde, it can be positive? You cannot. Gotta be negative, right?
Yes, I understand.
Yes. So if you look at your RVL, which is second catheter, right, true right ventricular catheter, lateral free wall, that small spiky thing is earlier, and then conducting to the now. Because of septum is connected to the motor band from that point. So conduction in the myocardium fairly fast, that area, okay?
Yes.
And then you got to look for negative potential, not the positive potential. Because unfortunately, tracing system that we had there is not too clean signal, noisy, unfortunate. That's the downside. You can see 60 cycle. So very hard to see. So you need to look at the reversed activation sequence of the right bundle potential. Therefore, it has to be negative, not positive. That's why that first notching is not right, probably not consistent.
Yes.
Okay.
So I have one question.
Yes, please.
So if we got right bundle branch block during catheter moving,
Yes.
is there any possibility to get complete AV block? Because
No.
the patient's left bundle
No.
branch block is functional. Yes.
No, we'll not get a bundle branch block. The reason is that transductor activation, you pointed out earlier, is going to happen. Patient not going to retrograde to the left bundle going up. Okay.
Yes. Yes.
Yeah. There is a very sad case. I have to tell you the story though. When I was a first year fellow, and I still remember 46 years old, a Filipino lady came to the our medical center. She undergone mitral and aortic valve replacement, mechanical valve replacement, because she had a rheumatic fever in childhood in Philippines. Anyway, and then after the OR surgery, and she was initially sinus rhythm, narrow complex. She became left bundle branch block pattern. So they thought that, well, during the surgery, we just knock it out the left bundle. But unfortunately, when she developed atrial fibrillation, she became very wide, complex, bizarre-looking tachycardia. Nobody knew what was going on. Certainly was not a nodal conduction. So we said, wow, there's something wrong. Maybe atrial fibrillation, IVR. So then we had a very hard time controlling her atrial fibrillation. So she going into the tachycardia. So they said, hey, why don't you take it to the lab, ablate the AV node, this lady put a pacemaker. Okay. So we thought that we just going to do the ablation. So we did the ablation. Guess what? Patient at the behind. So AV, aortic valve, mitral valve replacement, created a complete heart block on this lady. And then Mahan was dormant, woke up in the conducting left bundle pattern. We did not realize that. That was the most painful experience I had. So when we ablate the AV, it's behind, there we go. Patient was in heart block, asystole. So we just basically, everybody freaked out because what happened here. So anyway, that was a sad story about the whole this story. So maybe that lady, maybe should have controlled the atrial fibrillation left alone with the Mannheim conduction at least. Have no need a pacemaker, hopefully. But then we did not consider that even option. We just ablated, this pathway business, and that wasn't badly done. That's what the sad story about the whole thing. So in other words, we really need to think about things again, make sure that when you're ablating certain structure, make sure that's what you're doing and right thing to do. And that was my first Mannheim in my life. Well, almost killed me. So any other question?
Yeah, Dr. Huang, I have also one question for you. I
Yes.
read the textbook, and they also mentions about the long insertion AV bypass tract that is from the right lateral wall also that can make a differential diagnosis with the Mannheim, but I'm not fully understood about that. So could you explain me a little bit about it?
Okay, maybe you can look for, case study published already, right free or Mannheim like a tachycardia, a Mannheim like a pathway. That pathway also decremental, but not much as Mannheim. But also another characteristic of that pathway, they conducted antegrade retrograde both. Those pathway tend to insert a little bit longer than just typical right free pathway. And sometimes people get confused, but having fact that the pathway has a retrograde conduction, that does not really fit the Mannheim complex. So that's why you need most distinguish. But those patients, other feature that they tended to be pre-excited in sinus rhythm when you look at the ECG, because they would conduct antegradally faster, less decremental. Okay?
Okay.
Take a look at the paper. There's a published,
Yeah.
I think, 2007 somewhere.
So, like this case, long insertions, if you do PVC on his maneuver.
Well, it is a PVC is maneuver, not going to do much. The reason that you're both limbo decremental, antegrade, retrograde. Retrograde PVC going to go to the AV node, which is the decremental, may not advance your A too much. So best thing to do is that you pace from the atrial insertion, closed atrial insertion to PAC. Make sense?
Yeah.
That would be the best way to do. And then in order to identify location, also you can do, we call pre-excitation index. In other words, you pace close to the fast conducting pathway, your conduction time, close the pathway you pace, you're going to be shorter, more pre-excited. So we call pre-excitation index. If you pace from the CS versus a right free wall case, CS pacing have a long PR, like you saw example, and then you're going to have less pre-excitation. But if you pace close the right free where the pathway is, you stick to the QR is going to be shorter, you're going to have more pre-excitation. So we call pre-excitation index. Based on that, you can also identify where the pathway is. We used to do that in surgery many years ago when we had open our surgery. But we don't do that anymore because we got such a nice mapping. Okay?
Okay, thank you so much.
다 됐다.
Any other question?
혹시 52분이야.
Okay. Well done. Thank you very much for everybody. Well done, Nila. I hope to see you soon. Okay.
Yes.
Everybody have a good weekend. Hopefully have some rest. Okay. Bye now. Take care.
Thank you, Dr. Huang. Thank you, Dr. Nila. May I have one request to Dr.